Hey there. So the thing that we're going to do this week for an EMS training is going to be hopefully not too long, but I imagine it may take about a half hour. We'll see how long it takes to review all of this. What I'm basically going to review are the things that you see behind me on the board, which is a combination of a couple of courses. Some people have taken this with me here at the station in the past. It's kind of a conglomerate of the PHTLS course, which means pre-hospital trauma life support, as well as the TNCC course, which is the trauma nursing course that emergency department nurses have to take. And so I've put those two things together, and basically what we're going to cover here is how to do a good assessment of specifically a trauma patient. And it's a comprehensive formula with a direction and an order through the alphabet to be able to quickly and accurately assess a trauma patient and make determinations about what you need to do each step of the way. So as you see on the board, it's an A through I kind of acronym or abbreviation system, and we're going to go through that one by one, and that will be today's review to have a little bit of exposure to some EMS ideas. So the first thing you're going to see is you're going to arrive at a patient when you come on scene, wherever the patient is, and obviously the first thing we're always going to be worried about is that we have proper PPE, especially in this environment that we currently are living with the COVID-19 pandemic. We want to make sure, even in a trauma setting, that we're not exposing ourselves unnecessarily to the potential of that disease. So we have to assume that that's a potential when we get on scene. So it's going to involve the same things a non-trauma scene would involve as far as initial assessment of those issues. And then we want to make sure we're in the proper PPE and make sure that the scene is safe. And obviously we don't have the option in a trauma setting necessarily to stand by like we might in a medical setting if the patient is stable. In a trauma setting, unless they're definitely stable, we probably need to get involved. So then we want to look at, just like we always think about with any patients, our ABCs. But the first thing we want to make sure in a trauma patient is that there is no uncontrolled hemorrhaging. So that's the one thing that will distract us from airway. We need to pay attention to airway. Airway is of tantamount importance, but at the same time, if somebody has truly uncontrolled bleeding, and that doesn't mean that there's a lot of blood there, that means that they actually have a pulsatile arterial type bleed. So if they have a femoral artery laceration and they are literally pumping blood out of their upper leg, then we have to worry about solving that problem first, because if you fix their airway, that's going to be fine and you'll have them breathing with no blood circulating, so it won't matter. So you have to weigh those two things. So you have to quickly assess for that. If you see any evidence of large blood loss, you need to see if that's an issue. That might require you to pay attention before you worry about airway. Ideally, you can do both, and hopefully you have responders that are able to help one with one and responders that are able to help with the other, so you don't have to neglect the airway to control the bleeding. So then, bleeding is controlled, whether it's tourniquet, pressure, whatever the appropriate bleeding control is. This does not pertain to some bleeding. So if you have an avulsion of the lower leg and there's oozing venous blood, we're not worried about that till later. Then we want to go directly to airway. So we want to look and see, once we controlled any uncontrolled bleeding, we want to assess the alert status of the patient, and we want to assess whether they are alert. We want to assess the degree of alertness, so we can default to something like AVPU. We want to see, are they alert to their normal setting? In other words, are they just alert? Are their eyes open and are they responding to you appropriately? Are they only alert and open their eyes and look at you if you shout at them or talk to them and then close their eyes again because they're kind of in that state of being in and out of it? Or are they only alert to painful stimuli if you do a trapezius squeeze or you pinch a nail bed or something of that sort? And then the last level of alertness is that they have none, that they're unresponsive. So you want to quickly assess all of those things. Of course, we also want to, under A, assume spinal immobilization if it's appropriate for the mechanism of injury and or the setting and what we can determine at that point. So looking at the airway, we want to inspect the mouth and the airway. So you want to kind of look in the mouth and open the mouth. And if somebody's alert and oriented and they're talking to you, that alone suggests to you that the airway is patent. If they're not gurgling, if they're not if they're not having kind of rhonchorous respirations, if they're not having any issue breathing, their airway's fine, and so you can quickly go past airway. But if their airway isn't obviously fine, then you need to start to look into why it is that they're having problems. So you want to look and see, is the tongue an obstruction? Often with injured people that become somewhat unresponsive, the tongue, which is a large muscle, can fall back into the airway. The front loose part of your tongue that touches just behind your teeth with the tip of your tongue can actually fall back into the airway and occlude the airway. We want to make sure that there's nothing in the airway that's a physical thing. Do they have any knocked out loose teeth or some other foreign object in the airway, a piece of something that got in their mouth because of the nature of the trauma? If it was a car accident, sometimes that can happen. It depends what happened and what they're doing. So we're looking for foreign objects and then also objects like your teeth that need to be removed. Is there blood or vomit or secretions in the airway? In other words, are there things that can be occluding the airway that are naturally part of the human body but are in a part of the body they're not supposed to be? Do we need to suction those out? And then look for edema, so is there significant swelling? That's the kind of thing you see with exposure to toxins, and also heat, burns in your airway can cause that, as well as trauma. So if you have significant trauma to the neck exteriorly, that can cause swelling interiorly, and that swelling or edema can cause the airway to become occluded. So we have to worry about those things. Are they having snoring or gurgling or stridor? Those are all different sounds that the airway makes when it's not clear, and it depends what it is. Sometimes those need suction, but oftentimes the simplest thing they need is a repositioning. So as long as you can safely maintain spinal immobilization, sometimes you need to do a head tilt, or you need to do a jaw thrust if they have compromised spinal integrity, and you need to get that lower jaw up and out of the way. And then we can start to talk about oral adjuncts or nasal adjuncts, ways to keep the airway open for you or for the patient. Conscious patients will not tolerate oral adjuncts because their gag reflex will be very unhappy with you if you try to put an oral pharyngeal airway in an OPA. They don't like, because they're uncomfortable, NPAs, but you can place an NPA in a conscious person and they won't gag. And so even though they don't like it and they'll fight it, even if they're minimally responsive, they will tolerate an NPA before they'll tolerate an OPA. They have to be pretty much unresponsive before they'll tolerate an OPA without gagging. So we're going to move on to our section on breathing. So we've assessed the airway. The airway is not patent, and we've resolved problems that occur that cause it to be not patent, not open. We've put in an airway adjunct if we need to, and make sure that the airway is clear so that if the patient needs assistance with breathing, besides that repositioning and the adjunct, we can give it to them. Now we're ready to assess how they're breathing. And this all has to happen very quickly. You can't take 5 minutes to do this. You need to take seconds to do this. They need to get that airway open. They need to be suctioned quickly. They need to have the adjunct placed quickly. And you need to quickly then also assess after that, how are they breathing? So we want to look at their breathing. Is it spontaneous? So that's a really quick one, right? Is their chest rise? Are they breathing on their own? If their breathing is not spontaneous, we have to breathe for them, and that requires us to use a bag valve mask. When we look at their breathing, if it is spontaneous, or even if it isn't and we breathe with a bag valve mask, we have to assess the quality of their breathing. So is their breathing normal, or is it deep? Is there labored effort in their breathing? Do they have retraction in their ribs? Do they have neck muscles that are working hard that don't normally work hard to help breathe because they're using all of that to kind of expand their chest or to collapse their chest rather than the natural mechanisms that exist? And we want to look and see, are the sides of their chest both equally rising? So do they potentially have a pneumothorax or a hemothorax? Is a lung collapse so that when you're breathing for them or when they breathe, only one side of their chest rises? Those are things that we can't necessarily resolve at the basic EMT level, but knowing that will help very quickly get them the care they need when the paramedics arrive, because they can do a needle decompression and evacuate that air that's compressing the damaged lung on one side or the other. So you want to pay attention to those things and do the best we can to breathe for them, to ventilate them. So we're going to look, like I said, we're going to look at the depth of their breathing, the pattern of the breathing. Is it regular, or are they gasping, or are they breathing quick, 2 or 3 guppy breaths and long pauses and 2 or 3 guppy breaths? How quickly are they breathing? Like I said about the accessory muscle use, is there compliance poor for them, so they're not easily able to expand and contract their lungs, and so they're having to push with muscles to force the air out of their lungs, or they're having to pull with muscles to open the thorax in a more effective way, and they're having to show extra work of breathing. Those are things that you want. Those are things that you want to assess, and then you want to look. You want to look at their chest, and you want to assess, does it seem like they have any obvious injuries? Do they have displaced ribs? Do they have a flailed chest? Do they have a section of their chest where multiple ribs right next to each other are broken in multiple places? So that piece of the chest wall is no longer functioning with the rest of the chest wall. So when they inhale and the chest expands, that section actually drops into the chest. And when they exhale and the chest collapses, that section actually goes the opposite direction. It's called paradoxical motion. Those broken ribs aren't connected, and as a result, it weakens the whole structure of your thorax. That creates a suction or a vacuum by expanding, and then pressure by allowing your chest to relax. You have that section. One, it's very painful, and two, it minimizes the effectiveness of your body's ability to expand and collapse your lungs. So you want to look for that kind of thing. Excuse me. You want to see if there's any wounds. Like, do they have an open wound through the chest? Do they have a sucking chest wound? Is there a hole through the side of the chest wall right into the pleural space, into the lungs? Do we need to put a bandage over that? Do we need to put a 3-sided occlusive dressing over that so that we can help them be able to breathe and keep their lung from being collapsed by the air getting inside them rather than it being exhaled out through your vented trauma dressing? And we want to look and see how their skin color is, just in general, because that's a great indicator of circulation and breathing. If you're not breathing well, you're not oxygenating as a result, and you don't have good circulation, so you become pale and diaphoretic. And then we want to actually listen to the lungs, of course, as part of your breathing assessment. We want to hear the breath sounds. Do we hear them on both sides? So if you see unequal chest rise, the first thing you want to do is listen to the good side quickly and see what the side that's rising and falling, and see what they have breath sounds there. Yeah, okay, that's what they sound like. And then listen to the other side. The reason that works better is because your brain and your ears get a little reference from hearing the breath sounds on the good side, and the absence of the breath sounds on the bad side would be more apparent to you, rather than often will happen if you listen first on the side that may not have any breath sounds. You question, am I hearing breath sounds? Am I hearing? If you hear what the breath sounds sound like on the good side, if you hear something on the bad side, it'll be very diminished, and you're probably hearing referred air movement from the good side. But if you do the good side quickly first, hear a breath sound or two, then go to the bad side, then you'll be like, oh yeah, that does not sound right. And it's easier to get that mental reference. And then you want to look for things like subcutaneous air, which is that kind of Rice Krispies crackling under the tissue. That's often from a wound where a rib may have punctured into the pleural space from being fractured, and air is escaping. You may have a pneumothorax, you may not have a tension pneumothorax, you may have a small pneumothorax, but you get air leaking up into the tissue, and literally their skin becomes puffy, and you literally can feel the little bubbles of air caught in the tissue of the body, the muscle and the fat and the adipose, and it literally feels like little Rice Krispies or packing bubbles, miniature packing bubbles inside the tissue. It's a definitive thing that you will recognize the first time you feel it, but that's what you look for. Once again, there's not a lot that we necessarily can do to treat these things, but a good assessment will give that information to the arriving medics, and they can then try to assess what they need to do to be able to resolve the problem. We want to look for what's called jugular venous distension. That's a sign of your jugular vein in your neck expands and is over engorged, and you can literally see it if you turn the head to the side, especially to the left or the right side. You can see it on the opposite side, and it's the result of pressure backing up into the venous system because the thoracic pressure is increased because of a pneumothorax or a hemothorax, and sometimes lungs can shift side to side, and the result is the blood can't return to the heart as easily because everything's compressed in the thorax, and it shows as an engorged jugular vein. And so that's just another sign. That is most easily seen when the patient is sitting up at about 20 or 30 degrees. So that's semi-Fowler's position, with their legs extended and not lying flat, but just sitting up, part way in the stretcher or on a couch or in a bed or something like that. when people have JVD, that's a pretty late sign of a ventilatory compromise or a shifting of things in the chest. So we want to give them O2, obviously, for their breathing, and we want to give them either an OPA, an oral pharyngeal airway. If you're an intermediate, we want to think about if they need it, if we have to breathe for them, if they're unresponsive and their airway is compromised and we're breathing for them. The next thing we can do after an OPA is actually put a king airway in, which we have in our bags, right? Those are kind of a supraglottic airway. They slide in and sit over the airway opening, and then have a balloon that blows up there and another balloon that blows up a little higher to try to include the risk of air getting into the stomach. But the point of them is it's the closest thing you can do as an intermediate to intubation, and it allows you to ventilate people pretty well. They're quite effective, and if you really are having problems ventilating somebody, who needs to be bagged, who's not breathing on their own or is breathing so poorly that they need assistance, that supraglottic airway is the way to go, that king airway. All right, so the thing that's gonna be in your mind then is that the arriving medics are gonna very quickly consider actually intubating the patient, because the king airway sits above the entry to the airway, above the tracheal entry, which is right there at the under the epiglottis is the entrance to the trachea where your vocal cords are. They want to pass a more definitive airway, which is an ET tube, an endotracheal tube, will be slid through the vocal cords right into the trachea and then be secured there. And that's less likely to fail. So that may be something that you want to just have as an expectation. You may quickly find yourself assisting them with that kind of thing. So that's the basic breathing overview. For circulation, you want to, once again, you checked initially to make sure they weren't going to bleed out before you assessed other things. But now you want to look and do a little bit more thorough review of how they're circulating their blood. Look for uncontrolled bleeding again, just to make sure you didn't miss anything. And then you want to check their pulses. In this instance, if they're this damaged, if they're traumatized with enough injury, you can check radial pulses. And if you don't easily get those, then you quickly go right to a femoral pulse or to a pulse in the carotid on either side. Only do one side at a time for carotid pulses, but it's just better not to include the arterial flow to the brain on both sides, both carotid arteries at the same time. But you should be able to find a pulse in one of those two places. If you can't find a pulse there, you should be doing CPR. So we want to make sure they have a good pulse, that they're circulating blood, and we want to do our assessment visually of the patient. One of the things that circulation is the skin. That's just the simplest way to think of your assessment for circulation. Obviously, you check pulses, and you can put your ECG monitor on, and you can get an electrical rhythm that shows you they have electrical conduction in their body for their heart to be working and pumping. But what do they look like? Are they circulating oxygenated blood well? So what does the skin look like? What's the color of the skin? What's the temperature of the skin? What's the moisture of the skin? Is it dry? Is it moist? Are they diaphoretic, which is a symptom of poor perfusion or poor circulation? Is it cool? Is it hot? Is it red? Is it pale? All of those things are good things to assess that give you an indication of how the patient is doing. So a warm, dry, pink person is a relatively healthy person. A gray or ashen or pale, damp, cold person is a pretty sick person. So you want to be able to make those distinctions relatively quickly. Then we want to look, if we have the ability for circulation, is to be able to support their circulation. So one of the things that happens when you have a trauma is that you lose volume because you're bleeding, whether it's massive uncontrolled hemorrhaging, which is a big problem and tough to fix and resolve in a way that can save these patients if you don't have access to blood products. But they also can have relatively slow bleeds internally that we can't recognize, and those can be assisted by giving them more volume. Though the volume of normal saline as a fluid doesn't help them because it doesn't replace red blood cells, so it doesn't circulate oxygen well or at all, it keeps the volume high enough that the heart can pump what they do have in their system around and keep them as well perfused as possible. So if you need to, with a trauma patient and you're an advanced EMT, excuse me, you can place 2 large bore IVs is the recommended thing, at least 20 gauge, preferably 18 gauge, And the easiest thing is just to put them in the ACs. It's not the ideal location for the long term, but your job is to get access quickly and effectively, and allow the opportunity to give large volumes of fluid and or blood in a quick manner when those things become available. If you feel like the patient is hypotensive because of their volume being diminished due to bleeding, and you can start an IV, you're an intermediate, you can also give fluids. To do so in Maine, you need to call online medical control, which is no big deal. You just get on the phone and call the ER at Blue Hill, and you ask them, tell them the situation, have the vital signs, a quick scenario of what happened, what the trauma is, the age of the patient, the estimated weight of the patient, their alert status, and their vital signs, and I would like to give them a 500 milliliter bolus of fluid, and they're going to probably say yes. So you can ask to do that. If you think they've lost enough blood, the reality is they may need blood products. Unfortunately, the closest blood products are at the hospital here, so we need to get them there as quickly as possible. So we need to do everything we can on scene to be as prepared as possible for when Peninsula ambulance arrives or Bucksport ambulance arrives. And the knowledge that you want to have from your assessment is to be able to pass that on to the arriving paramedics so they understand the urgency of the situation, in that you can tell them what's happened and that we've already given, they were hypotensive, and if they were truly hypotensive, like if they were 70 over 40, and we've already given a liter of fluid in conjunction with orders from online medical control, and our blood pressure has not improved very much at all or has gotten worse, they're going to know that they're going to need to expedite to the hospital as quickly as possible. The other thing you can always think about, a little plug for my job, is if you have a patient injured that badly who is that hypotensive, they need blood products, and they probably need to be at a trauma center. And so you can do your assessment, and you can suggest that Lifeline be called to the scene to transport them, because we do carry blood, and that often in these severely injured patients is the difference between them making it to the hospital or not. So that's an important thing to think about, that kind of assessment. Do you think this patient is stable enough that they can be 15 more minutes with us, and 30 or 40 minutes, 30 minutes to Blue Hill, and then another 15 or 20 minutes before Blue Hill can get blood, together from the lab and infused in the patient? So are they going to make it an hour without that blood product? If not, if you don't think they're stable enough to do that, then calling Lifeline is a good idea. And it's always a good idea to activate or ask to activate Lifeline in a major trauma situation. And if Lifeline isn't needed, you can cancel them. That's not a big deal, but it's better to have them on the way with that potential need than it is to not have called them and then have no option to help the patient. So moving on from circulation, we're going to go, to disability. And that's what the D stands for. And the disability is really a neurologic assessment. So we've checked our airway, our breathing, our circulation. We've done the things we need to do at those stages. And that's the important thing to think about, the way you address each of these things as you come across them. If their airway isn't patent, you need to fix it. In other words, I don't care what their neurologic status is if they're not able to breathe on their own or we need to breathe for them. You stop and fix that problem. If their circulation isn't good, if their breathing isn't good enough and we need to breathe for them when we get to B, we stop and we fix that problem. We don't go on to C or D, because these are prioritized in importance. And then circulation, if they're hypotensive and they're bleeding and they need some wounds addressed so bleeding can be controlled, they need a tourniquet applied or a tourniquet tightened or a second tourniquet applied. Maybe you applied a tourniquet to that thigh that was bleeding arterially and it controlled the bleeding to some extent, but didn't stop it completely. You realize on your circulation assessment as you come back to it, throw a second tourniquet on it above that one if you can. Sometimes you run into the groin, which means that's as high as you can go, but you do the best you can, or you tighten the tourniquet you already have. But you don't stop and you don't move on to the next letter of assessment or the next progression in your assessment until you resolve the problems at that level. And so, once again, if they need breathing assistance, if they're not breathing on their own, you need to breathe for them, and you need to address that before you go on to see what their skin tone and moistness and color and temperature is. Because if they're not breathing, that won't matter in the long run. So we get to D, which is a neurologic assessment. We call it disability. We're talking about neurologic disability. And so we're going to fall back onto our Glasgow Coma scale for this basic assessment. And so we want to look at the eyes. Those are a great window to the soul, as it were. Pupils remain reactive for a long time with major neurologic injury. And when your pupils stop reacting to light and are no longer equally reacting, one side equal to the other side to light, you are having pressures with increased issues with increased cranial pressure, intracranial pressure inside your head. And the result of that is potentially terminal or fatal if it gets high enough and the brainstem gets compromised. And so that's what that's telling you. So that tends to be a late sign of major head injury or neurologic deficit, but it's a quick thing you can check quickly. How are the eyes? Equal and active, okay. And then you want to assess their Glasgow-Coma scale. How are they responding to you neurologically? So that's a 15-point scale, if you remember. Are their eyes open? And there's points given for each one of these assessments. So the first assessment level is eyes. That's a 1 to 4 point scale. If they're open and looking at you, that's a 4. If they don't open at all, that's a 1. Are they, what's their verbal status? So do they give verbal responses? So when you talk to them and they respond to you, are they speaking clearly and making complete sense? That's a 5. And if they have no verbal response, that's a 1. And then motor, similarly, that's a 6-point scale. And if you look at it and assess it, if you say to them, can you please touch your finger to your nose, that's a 6, right? Perfect motor control. And they can do that with all of their extremities and they can follow you with their eyes. That's all good motor control. That's a 6. 0 response neurologically. They can't make anything happen or nothing happens. Like they don't respond to significantly painful stimuli. The last two at 1, 2, those are actually contractions. So are they responding to significantly painful stimuli with decorticate or decerabit contractions? And those are signs of significant neurologic damage. And if you have decerabit, the posturing that results in the body flexing, the arms and the legs kind of flexing out away from the body, from the core, that's the worst case scenario, and that would be down there in the 2 to 3 range, and a 1 is 0 response, right? There's no neurologic response at all. And so, as you can see, the lowest number on any one of these categories is a 1. So 0 response in any way, shape, or form is a 3. Just like this table, we like to say when we teach the Glasgow-Coma scale. Even a table has a GCS of 3. A comatose person has a GCS of about 8. A person that's 14 or 15 is doing pretty well, but once you start to drop below 13, you're starting to have significant compromise in one of those, if not all of those categories, if that makes sense. So you want to refresh that. You want to be able to look that up on your phone, especially for us in the first responding volunteer setting. We may not have that at the tip of our tongue. And so we want to be able to use that tool so we can tell the arriving transporting agencies personnel what the GCS is. And the important thing about the GCS is it's used kind of as a tracking tool. So if when you got there, the patient was a 15, and then the ambulance comes 10 or 12 minutes later, and now the patient, you look at them and you say, wow, they're really only at 12 or 13 now. They're decompensating pretty quickly. And so that's a useful tool to be able to assess that. So that's what we're talking about as far as disability, under our D. Under our E, the next thing we want to do, we've done a neurologic assessment, is we want to expose them completely so we can check their whole body, and we want to make sure that we can see any other injuries that we might have missed. Our patient's relatively stable, at least as far as we can stabilize them. We've taken care of their breathing. We made sure their airway's clear. We've made sure that they're breathing on their own or that we're assisting their breathing adequately. We've made sure initially that uncontrolled hemorrhaging is controlled, and we made sure that their circulation as far as their volume, if we have somebody on scene that can help replete their volume with a bolus of normal saline. We're doing all of those things. And those are kind of treatment modalities. And now we're more in the assessments phase of this thing for a more detailed assessment. We've assessed their neurologic disability, and now we're looking physically at the rest of their body. We're exposing them. The thing to think about here is a lot of times trauma happens in the outdoor world, and we often find them somewhere in the outdoor world, whether that's stuck inside a car in the cold in the middle of winter, or in the woods, or at least lying in the yard next to the house where they fell. And you need to think about the fact that one of the major things that makes trauma patients get more sicker, I guess, is not more sicker, but get sicker or have more problems is being hypothermic. Hypothermia or low body temperature, contributes greatly to problems with clotting and a whole number of more complicated physiologic things that result in trauma, causing lots of other problems like multi-organ failure and DIC, the inability to clot, and people having major hemorrhagic problems from trauma. So keeping them warm is important. So though we want to expose them, we want to consider the environment in which we find them, get them up off the cold ground, get some blankets under them. If we have to, put them on a backboard and put blankets on that and get blankets over them and expose them, but then make sure they're kept warm. Break some hot pads and wrap them in pillowcases and put them in their axilla and their groin or on their chest underneath the blankets to try to do as much as we can. Wrap their head if you can with a blanket. Do whatever we need to do to keep them warm if it's a cold environment. Excuse me. Our goal is to keep them normothermic. Try to keep their body temperature at its normal level. And then we want to move on from that expose and examine. We want to look and see if there's anything we missed in our initial assessments quickly. This is the time to kind of slow down and just examine everything. Do you realize, part of their foot is kind of not the way it should be. It looks like it's kind of disjointed or out of line, suggesting maybe some fractured bones in their foot or their ankle, or I just found that the back of their calf is avulsed and there's no skin on the back of their calf. Maybe it was a motorcycle accident. They literally just ground the skin off their calf, and I didn't notice that because they're not really bleeding from it that much. It's kind of oozing a little blood and their jeans are wet, but now that we've exposed them and gotten down to seeing what that is, we see that there's no skin left there. So we want to get all of those details of our assessment in and be able to communicate those, or maybe now do the appropriate dressing since we've stabilized the other things. If we have enough personnel on scene to maybe dress that, clean that up a little bit, wash it with a little bit of our irrigating saline and dress it with some, maybe some damp sterile gauze and some Kerlix just to keep it protected for the transport. And then we want to move on to now a truly full set of vital signs. So once again, to the best of our ability, we've stabilized the patient, we've exposed them, we've found any other injuries, we've addressed some of those if we need to, maybe we stabilized some things, maybe that ankle was broken and it needed to be put in a pillow splint, or we need to put it in a SAM splint somehow. We've done all those things. Now we're going to really assess their full set of vital signs. We got their blood pressure with their circulation and we've got their pulse and that kind of stuff, but now we're going to stop. Now we have time. We're going to check out their SpO2. We want to reassess. Now we've done all these things. We want to get a full set of vital signs on them. Get them hooked up to the cardiac monitor if we haven't done that and we have an advanced EMT available. So that's just another ability to reassess, see where we stand, how have we done, have we stabilized their blood pressure with our interventions, are we breathing adequately for them, are we ventilating and oxygenating them, all of those things we can look at with our full set of vitals and have an idea of how we're doing. And we may not get through all of this before Peninsula Ambulance gets there, and that's fine. But we want to progress in an orderly fashion, and that's kind of the suggestion of this whole presentation, is to work our way through this orderly progression to hit the high points that we need to make sure we're doing the best we can for this patient. And then the next thing is, the G after the F is kind of get more stuff, and that's something I already mentioned with the full set of vital signs in a sense. Get the cardiac monitoring on, get the pulse oximetry on. If you want, you can pull out the nasal cannula end-tidal CO2, which is a great indicator of perfusion and will let us know how well we're breathing for the patient, if we have to be breathing for the patient, getting that end-tidal number on our monitor, and it will help us assess whether we need to slow down our breathing or increase our rate of breathing, as well as give us a baseline to trend. Is there end-tidal CO2 going up or is it going down? And so those are useful pieces of information. And then we can also assess the pain the patient is experiencing. Once again, we can't do a lot for that. Technically, we have the access to orally dissolving Tylenol, though we don't carry it just because its use is relatively limited. But if they have significant pain, we want to see if any of our splinting can help that, positioning, trying to get them to calm down and relax if they're conscious, and then communicating their level of pain to the responding transporting unit. And then We go on to H. H is just a return to that full expose and examine thing. Now we're going to make sure we're going to start at the head again, and we're going to do a full head to toe assessment. We're going to look at everything. We're going to look at their head, their face, their neck, their chest. We're going to listen again. We're going to look at their abdomen. We're going to palpate their abdomen, see if there's any distension or unexpected firmness, or if it is still soft and tender, soft and non-tender, or if it is tender, if they're alert and can tell you that. So we're going to look at everything. We want to have a sense of if things look out of normal, if there's bruising, if there's firmness and swelling anywhere that we didn't notice before. We want to look in the groin, so we want to look at the pubic area, and we want to look at the perineum around the anus to make sure that we don't see any evidence of major bleeding in the pelvis, because you can get discoloration there and swelling there that suggests internal bleeding of the pelvis. And if that's true, at that point, we may want to consider a pelvic binder if we also find some pelvic instability. You have to be careful with a pelvic binder. It's really designed to do one thing, which is close what's called an open book fracture, where there's a couple of places the pelvis is broken and you can compact it and kind of contain it together with that binder. But if they have many fractures, in other words, if the pelvis really feels tremendously unstable, a pelvic binder is probably a bad idea, because it's going to move lots of smaller pieces of bone grinding against each other rather than just closing those couple of fractures that have caused it to be unstable. So if it feels like a bag of rocks, you don't want to move it. And you also have to be careful, because you don't want to be too aggressive with your pelvic kind of tilt or rock or assessment. We used to do a pretty aggressive pelvic tilt and kind of rock and see. But if it's broken and you do that too hard, you can move a lot of stuff, which can damage more tissue and cause more bleeding. So you just want to do a quick but accurate assessment of that pelvis and make a determination about those things. And then we want to look at all of the extremities again, head to toe, once again, all the way out to the fingertips and all the way out to the tips of your toes. And then we want to go on to our eye, which is our inferior or back side. If we haven't rolled the patient and looked, we want to do that. If we need to maintain spinal immobility, we need to do that. So you need to have that person continuing to maintain that with the person with a C collar and holding the head, and that person will lead the charge as far as the instructions to roll the patient so we can inspect the posterior. There could be a posterior wound that's bleeding. You might find other spinal abnormalities, step-offs, or the spinal column is no longer in line. It just depends. You never know what you're going to find. You could find significant bruising in the posterior, either from kidneys or on the lower left side of the back there. You might find significant bruising, discoloration, and swelling, which could be indicative of perhaps a ruptured spleen, which is a significant problem because it holds a tremendous amount of blood. And if the patient is bleeding aggressively from a ruptured spleen, it may be very hard to get them from wherever they are to a hospital, because that requires emergency surgery and often lots of blood between the time of injury and the surgery just to keep them alive long enough to do the surgery. And then that's pretty much it. We want to look at all of those things. And then the thing we do after this, we could be breathing for the patient, somebody right now with an oral airway. We could have a pelvic binder on. We could be infusing large quantities of normal saline if we have the level license that we need on scene to do that. And things may not be good. In other words, the patient is not getting better with us, but we're just trying to keep them alive and keep them from getting worse. And if we are still running the scene and haven't turned over care to the transporting ambulance, the next step is to think about doing this process over. Constantly be reassessing the patient. Constantly be making sure, is the breathing still working? Are we still getting equal chest rise when we breathe? Is our adjunct that we have in place adequate? Do we have good breath sounds? And go through the whole process again, over and over again, head to toe. And then you just want to have all that information available to pass on in a concise manner to the transporting agency. So that pretty much covers in a very short period of time something that can be as much as a 6-hour course with more detailed reviews of each of these points, and then some hands-on learning as far as scenarios that we can walk through. And some of you have done that in the past and will, of course, do that in the future. But I just thought this would be a good thing that we could present to everybody in a relatively quick manner to give you something to contemplate and to review, to keep your mind sharp about EMS issues. Thank you very much for watching, and we'll see you next week with some more information.